I'm Dr. Jessica Maxwell, also an assistant professor at the University of Nebraska Medical Center, and she is with our surgical oncology team, a breast specialist.
Good morning, everyone. Thank you for having me today. As Dr. Benny mentioned, I'm one of the breast surgical oncologists here at UNMC and at the Med Center. I'm going to be talking today about surgical and cosmetic considerations after neoadjuvant chemotherapy for breast cancer, specifically as it relates to radiation oncology. I have no disclosures. So what I'd like to do today is discuss the safety and feasibility of de-escalating surgical intervention after neoadjuvant chemotherapy, and also talk about oncoplastic surgery, which is my area of specialty and a tool that we can use to help de-escalate surgical intervention, and differentiate between level 1 oncoplastic surgery and level 2 oncoplastic surgery. And then finally review the indications for axillary management after neoadjuvant chemotherapy, specifically discussing sentinel node, targeted axillary dissection, and complete axillary dissection. From a surgical perspective, there's been a long-standing trend to de-escalation of surgical intervention in breast cancer, so much so that it's a recurring joke at every breast oncology conference that eventually the surgeons will be out of jobs. So far, not yet, but we're definitely moving towards less and less surgical intervention. And we know that neoadjuvant chemotherapy allows for a safe decrease in surgical intervention. It doesn't replace surgery as a treatment option, but it does allow us to potentially convert from a mastectomy to a lumpectomy or breast conservation. And we'll talk a little bit more about the use of oncoplastic surgery to kind of extend the indications for lumpectomy and what that means from a radiation oncology standpoint and what considerations have to be made. And even within the realm of mastectomy, it may allow us, neoadjuvant chemotherapy may allow us to switch our approach from a non-nipple sparing mastectomy to a nipple sparing mastectomy and allow us to preserve the nipple areolar complex in patients to get optimal cosmetic outcome. In those situations, what we generally do is image the patients preoperatively or pre-treatment, treat them with their neoadjuvant chemotherapy, repeat their imaging to assess the tumor response, and then make a final surgical decision at that point. In patients where we're considering the transition between a nipple sparing or a non-nipple sparing approach versus a nipple sparing approach, in general, what we do from a surgical perspective is take a separate margin at the base of the nipple intraoperatively. And if that comes back as positive for disease, then we would excise the nipple areolar complex. But if it's negative, then we can leave it in situ and allow for the better cosmetic outcome. And then from a lumpectomy standpoint, we can, even in patients who are candidates for breast conservation before neoadjuvant chemotherapy, we can shrink the tumor down with neoadjuvant to allow for smaller volume tissue removal at time of surgery, which can then allow for better cosmetic outcomes. And then we can potentially downstage people from full node dissections to a sentinel node versus a target axillary dissection, and then save them significant risk of lymphedema going forward. So with respect to the breast, we've had multiple studies that have demonstrated a significant decrease in tumor size in a large number of patients after neoadjuvant chemotherapy. The NSABP B18 studies showed that there was 80% of patients who received neoadjuvant chemotherapy, all comers, all breast cancer subtypes, have some decrease in tumor size. We do see a stronger trend toward pathologic complete response in women who have triple negative breast cancer or HER2 positive breast cancer versus ER positive breast cancer. But overall, we do get some decrease in size in the majority of patients. In this study, there was 12% more lumpectomies done in the neoadjuvant group versus the adjuvant chemo group. And overall, in women with greater than 5 centimeter tumors, there was a 175% increase in lumpectomies in patients. So the larger tumors were really kind of shrink down quite a bit. And then a meta-analysis done in 2017 showed that neoadjuvant chemotherapy did lead to higher rates of lumpectomy or breast conservation, that there was no difference in distant recurrence, breast cancer survival, or overall survival. They did demonstrate an increase in local regional recurrence at 15 years. Additional studies have then shown that there was no increase in local regional recurrence in patients who downstage from mastectomy to breast conservation after neoadjuvant chemotherapy. And then there is no difference in local regional recurrence after neoadjuvant chemotherapy with respect to surgery type. So the question here becomes, is it safe to excise the residual tumor volume and not the tumor bed? And I think that question is something that we discuss a lot. And to the best of my knowledge, and we've discussed this before, that there's not a great study, there's not great data out there comparing full tumor bed excision. So say you had an 8-centimeter tumor pre-neoadjuvant, shrinks down to a 2-centimeter tumor, but surgically you still remove that 8-centimeter tumor bed versus just a 2-centimeter area of residual disease. There's not great studies directly comparing those two. So I think the question then becomes, where is your cutoff and when is it safe to downsize surgery versus not? And I think that depends a lot on tumor recurrent or tumor response to the chemotherapy and their overall risk in general. And that's something that we discuss regularly in our multidisciplinary tumor boards. I would say that although there's not great studies comparing these two head-to-head, the vast majority of surgeons are not excising the full tumor bed after neoadjuvant chemotherapy, because that removes the benefit of downstaging your surgery. If you're going to take out the tumor bed, regardless, you're probably not going to be able to change from a mastectomy to a lumpectomy. So I think anecdotally, that's probably practice patterns. However, we don't have a great study comparing the two. So oncoplastic surgery is a great tool to de-escalate surgical intervention, especially after neoadjuvant chemotherapy. Essentially, the goal of oncoplastic surgery is to perform a lumpectomy, resection of the tumor to clear margins, but to really consider excellent cosmetic outcomes in a single procedure. And it allows for increased volume excision with optimal cosmetic outcome. So there are two levels of oncoplastic surgery, but what I always tell people is that the main goal of oncoplastic surgery, to put it very simply, is to take the tumor out and make things look good when you're done. And the way that you do that really is recentralizing the nipple areolar complex and filling in the gap that you've created by removing the tissue. So level 1 oncoplastic surgery is essentially just reapproximating the glandular tissue underneath the skin to prevent the puckering of the divoting or the contour deformity that can occur when the seroma absorbs and with radiation. Level 2 oncoplastic surgery is a little bit more involved, and this involves really moving the nipple areolar complex around and removing skin, reshaping the breast to provide optimal cosmetic outcome. This is things like doing a breast reduction to take the tumor out, things kind of along those lines. Level 1 oncoplastic surgery, the just basic glandular reapproximation, this can be performed by any surgeon without really a significant amount of additional training. And so I think this is something that from a radiation oncology perspective, you'll likely be seeing more and more of as this surgical approach gains popularity. Level 2 is still a little bit less common because it does require additional kind of specialty training, either fellowship training or with your plastic surgeon. So fewer people doing this, but still something that you may come across. The big thing about oncoplastic surgery from a radiation oncology perspective is that the scar has nothing to do with the tumor bed anymore. Really, you could be working well away from the scar with respect to where you may be targeting a boost. So you really have to rely on your surgeon to mark the tumor bed with clips accurately to allow for you to have an accurate target for your boost. And so that means marking really at the chest wall. And one of the principles of oncoplastic surgery is you do take your dissection down to the chest wall every time and take back fascia, even during the lumpectomies. Allows for easier movement of the tissue along the chest wall, but also allows us to place clips right at the chest wall so you, as a radiation oncologist, know where we were working. And from a surgical de-escalation standpoint, you know, there's been consensus that, that as we discussed earlier, that we really favor excising residual disease, but not the baseline extent of the disease or the original tumor bed. And then I think importantly, the axilla is where we have made significant change over the past years in looking at sentinel lymph nodes, post-neoadjuvant chemo in patients with node-positive disease. Currently, the NCCN guidelines do recommend sentinel lymph node targeted axe dissection in patients with clinical N1 disease at presentation rather than just jumping to a complete dissection. But this requires some planning. So a sentinel node or a targeted axillary dissection post-neoadjuvant chemo means that we must clip the node at time of biopsy at presentation to allow for the surgeon to localize the node after neoadjuvant chemo. We do that here with a radioactive seed, which you can see right here, and a biopsy clip. So biopsy clip goes in at time of diagnosis, radioactive seed goes in at time of surgery to allow us to localize that lymph node. We take out that lymph node as well as at least 2 additional lymph nodes with sentinel node, and we send them for frozen section. And if there's any residual disease on frozen section, we do move to a complete axillary dissection, whereas if the disease has been eradicated by the chemotherapy, we stop there and we don't complete the axillary dissection. So this obviously has implications from a radiation standpoint when you're considering what fields to include in your nodal radiation. So overall, I think the big message here is that de-escalation of surgical intervention in both the breast and the axilla is feasible and safe in appropriate patients. There are certainly advances in breast surgical techniques over the past decade that have allowed this to be possible and still achieve good disease control and better cosmetic outcomes. That being said, there are patients who will always require maximal therapy with modified radical mastectomies. But I think when we're talking about this, there's been such a focus on survivorship in breast cancer that it's important to consider post-treatment body image, sexual and psychosocial function in addition to your disease control. Thank you very much.